Hey everyone, and welcome to Empowerment Unplugged with Vicky Deutsch. This is our second episode, so bear with me, guys, as I navigate this fun and exciting adventure. We are a podcast that we don't tiptoe around the truth. We say it as is, and we're not here to sugarcoat anything, and we're here to empower women one episode at a time. Today, I am honored to have a very esteemed guest, an OB-GYN, who has been making it his mission to empower women, talk about the taboo subjects that most providers don't want to talk about, and make birth back to its original form, which is positive, empowering, and let women know their rights. Most of you may know who he is. Most of you probably follow him, but if you don't, please do so. He has amazing episodes, amazing knowledge, and it is none other than Dr. Stuart Fischbein. I'm super excited about this.
Super excited. That's like somewhere between excited and like infinitely super excited.
Exactly. I've been following you for a while now, and what intrigues me is, I'm just going to dive into it, is that you're OB-GYN and you're speaking up and you're sort of not staying silent like a lot of providers do when it comes to women's health and the hospital system and the world out there. And I'm curious as to why you're so passionate about it.
Why am I passionate about birth? Because it literally is one of the most important things on the planet. And why am I different than my colleagues? That's a complex story. It has to do with upbringing in psychology. It has to do with experiences in life. It has to do with mainly that right now, and for my entire career, I've been self-employed. I haven't had masters. I haven't had people telling me that if I speak out, I'm going to be fired or suspended or whatever. I have my eyes open. I think most of my colleagues have a very strong cognitive dissonance. If they don't know what they're doing is harmful, that's hard for me to fathom. Because you can convince yourself of anything. You can convince yourself that a third of all women need to be induced and 40% need to be sectioned and 10% of babies need to go to the NICU and we need to do all these interventions and without the outcomes getting better. And you can convince yourself that you're doing something good, but that's delusional.
Right.
So they have to have cognitive dissonance, which is that they find a reason to justify what they're doing, because the alternative is unthinkable, that they're actually doing stuff that they purposely know is damaging to women. So I broke out of that a long time ago. And mainly I give credit to the local midwives when I was living in Los Angeles, who approached me early in my career and asked me if I would just take their home birth transports. And I had no knowledge about home birthing other than what we talk about in the resident lounge and the doctor's lounge. And generally, it's not positive.
No.
But I did it because, again, being self-employed and being in an era back then where, you made money for the work that you did and you didn't get paid a salary and work a shift and, have a job and have a pension plan and all that stuff. You had to do all these things yourself, and you had the overhead, you had your own office, you had to do all those things. So you were looking for sources of revenue, and I found that to be a nice stream of revenue. Little did I know that it was going to turn out to change my entire life. Because I began to see another way of doing something simply because I would spend time talking to the midwives who were gracious and knowledgeable and, not the stereotype that we were told or taught in the medicalized industrial complex, where we're brainwashed to believe that our system is the best system for taking care of women, and that women and pregnancy itself need to be taken care of. I mean, even that sentence that I just said, that we're taking care of women, this is how we're trained. We're trained that pregnancy is an illness, pregnancy is a disease, pregnancy is something that's going to go explosive in any second. Right. And so we are taught to manage those things. And we can't differentiate anymore between a woman who needs management and one who doesn't. And I just was lucky. Again, I was lucky, and I give credit to my parents, and I give credit to my upbringing and my friends who made me curious and intellectually challenged in that way. Not me challenged, but challenging the status quo. I often say that I was a little annoying kid that kept asking my mom why when she would say something.
Those.
And eventually she get exasperated and she would say something like, because I said so. And because I said so doesn't sit well with me. And that's the kind of thing that you get now in medicine.
Exactly.
Why are we taking the babies to the warmer? Well, it's our policy.
Policy is a big word for everything, I find.
Correct. But that's like the little kid who's being told, that you can't have a cookie. And it's like, well, why?
Why not?
Well, it'll spoil your dinner. No, it won't spoil it. But you can't, when you're a kid, you can't debate these things and argue these things. You just accept them. But I grew older. I became more rebellious and challenged things. So, I can't put one finger on something that how I got to the point where I am right now, but it's easy to be me because it's easy to advocate for something you truly believe in.
100%. I always say if you're on the other side and you actually see it for yourself and you understand, then it's, like you said, it's easy to just how could you not advocate for it? How could you not advocate for women's rights and taking back that pregnancy, delivery is not a medical emergency. Medicine is there for a reason, I always say, and it's a beautiful thing, and it's meant to be used, but in balance and when it's needed, not when it's not needed.
Yeah, the example that I often use for that to make it very easy for listeners is that conceiving a baby, growing a baby, going into labor are all primitive bodily functions that you don't have to think about. They're lower brain functions or they're bodily functions that are just routine. And it's very similar to breathing or digestion, which is obviously something we don't have to think about until we have a bad cold or until we have diarrhea or until we have some other problem, which may then lead us to seek medical attention. But for the most part, we don't need it. And it's the same thing as you said, pregnancy is not an illness until it becomes one. And like anything in life, sometimes things go wrong. And that's where you need the medicalized system and you need the specialists and you need the instruments and you need the interventions and stuff like that. The problem, of course, is that everything about the way the system is set up to basically support the system. It's not there to support the individual woman or women in general. Just because they have a good live baby doesn't mean they did the right thing. And, in every paper that you look at, when you look into the research in obstetrics, the only endpoints that matter are fetal mortality and fetal morbidity. They don't really look downstream at how that baby's doing 2 years of age. They don't look at how's the baby's microbiome. They don't look at how the baby integrates its reflexes and how is it doing. Is it wetting its bed? Is it having attention deficit disorder? Is it having other issues? They don't look at how the mom did. They don't look at how mom's psychology was. They don't look at how mom's breastfeeding success was. They don't look at how mom did in future pregnancies. They don't look at the relationship between the woman and her partner. None of those things matter. They can't quantify them. They can't calculate them. They can't use statistics on them, so they don't pay any attention to them. But when you step back and look at the bigger picture, you can actually see that these things are the things that really matter. And what we're doing to our children, who then grow up to be, adults and then reproduce, has not been beneficial over my lifetime. I have seen the deterioration of the health of America and other countries as well, but we're speaking mainly about America here. Despite, or maybe, not despite, but because of the medical interventions and the medical technology that's been created. These things are generally profit driven. C-section rate's gone up 600-700%.
100%.
And the rate of cerebral palsy and the rate of neonatal death, which are the two main endpoints that all these papers are looking at, have not gotten better. If you're going to do interventions, then you should actually know that they're actually beneficial before you do them. And the history of medicine is such that they do just the opposite. And from, in the last 100 years, I could rattle off a dozen or more things that the medicine has done that have been catastrophically bad, but they did them anyway. From putting mercury in baby's teething powder to spraying us with DDT to thalidomide to diethylstilbestrol to Vioxx to the whole vaccine issue and the toxins, the mercury, the aluminum, to ultrasound. In 1970, about 1 in 3 women had an ultrasound. Now, I think every woman has an average of 3 to 4 ultrasounds with no concern about the non-ionizing radiation that comes from that. And pretty much every one of them turns on the color flow Doppler. It was never designed to be used as a screening tool, but it had mission creep because it generates revenue for them. And every time you make a client worried or fearful, you generate a client that's going to come back in a couple of weeks for another scan.
Correct.
And does that sound nefarious to people listening? Yeah. It's dastardly. And yet that's their standard of care, which, by the way, is another term that doesn't mean anything. Standard of care is what a typical physician in a typical situation would do in that community. But if you're the first person in that community that's doing something like a breech vaginal delivery, you're outside the standard of care. And yet you have a better standard. So the term, when people use the term evidence-based medicine or standard of care to justify what they're doing, they're not thinking. And my profession is filled with something called stage 1 thinkers. Stage 1 thinkers are thinking about doing something, and it's often motivated by money. But stage 1 thinking is doing something because you think it will do good or it may make you feel good, but without ever asking the follow-up question, does it actually do any good? And the things that I were talking about already that I was listing off, like thalidomide, ultrasound, and all these things, I'm not lumping them in the same group, but they haven't improved outcomes. And ultimately, isn't that the mission of medicine, is to make people healthier? And yet, if you look at our overall population, in no age category are we healthier. In fact, in the last 5 years, since COVID began, actually since the COVID vaccine began, all-cause mortality in every age group has risen. So what are we doing?
So what would you tell women who are looking for providers? What is something they should be looking out for? How could they find providers that are really on their side? On the flip side, when I recommend people to midwives, it's this typical, as me and you have heard many times, they're not as qualified as OB-GYNs. I don't want a midwife, and they almost even lump them into as if they're like a doula when they're not.
How do you do that?
What can you say about that?
You do that, well, first of all, there's the old golden rule, them that has the gold makes the rules. You've heard that?
Yeah.
So the medical industrial complex has the gold. And so they make the rules. But if you take a step back and you get out of that idea that we're supposed to trust our doctor, and I'm not telling anyone listening to trust me, you have to do your own homework. And it's getting harder to do your own homework, despite the fact that you have all the computing power in the world in your pocket. What's out there on the internet is filtered. And you're fed information based on whoever's paying the most to Google or moving the things up the ladder or whatever. So it's very hard to even know what to do. So once you find a trusted source, then that's something that you can start as a baseline and figure out to go from there. But I would not trust the average allopathic medical doctor in 2025. I wouldn't trust him in 2020 or 2021 or 2022 either. And we learned that because my organization and many of the organizations are still pushing COVID vaccines on infants and pregnant women. Anybody who's doing that is not somebody you should ever trust for any piece of information ever. But so don't distrust me. You have to do your homework. And the problem is most people don't want to do their homework. They've been indoctrinated to believe that the doctor has their best interest at heart and that the local hospital has their best interest at heart. And the local hospital has a PR department to make sure you think that. They have commercials on, if anybody still listens to radio anymore, but they have commercials on social media and stuff like that telling you how great they are and all that, and that they really care about you and stuff like that, but they don't. If you do good at a hospital, that's a bonus, but the hospital's main job is to keep the hospital functioning and open and to generate revenue. And the two are in conflict because sometimes what's best for you isn't to generate revenue for the hospital, yet the hospital will choose that path. They'll order more tests. They'll make you come back for other things. They'll give you medication that you could have treated maybe naturally. They'll do these things. That's the way that system, and that's the way the doctors are taught. It's the way the medical system taught. So there is no simple answer, but the biggest answer is for each individual person to take personal responsibility for their own body and their own family and not trust an outside source that they've been told to trust. Because again, it all gets down to outcomes. If the medical system was doing so well, then we'd have better outcomes. And we don't. So start at the beginning, before you're even pregnant. If you're thinking about getting pregnant, or even if you're single and you haven't even thought about it yet, but you live in a community, take a day, take a few hours in a day, go over to your local hospital, talk to the labor and delivery people, check out the other hospitals in your area, check out, the options that you have in your area. When you move to an area with a family, you check out the schools, you check out the churches, you check out where's the Costco, you would check out the safety record in the town, those sorts of things. Nobody checks out the hospital. Nobody checks out the medical community. They just assume, well, I got a Blue Cross card. I'll just go to whoever my provider is, and I'll just
insurance.
Correct. Big mistake. So along with checking all these things out, start very early in life with, a health savings account, so that you're not confined by your insurance card to the one choice that you may have. You have a choice of going to a doctor who doesn't take your insurance, who might be a better person to have a better reputation or better statistics or just a nicer person. That's one thing. So health savings account, doing your homework. We need to educate our teenagers that pregnancy itself is not a disease, that their body works fine. We need to talk to them about their menstrual periods so that it's not this gross thing that, little girls are grossed out by and little boys are grossed out by because, they come up with these things like she's on the rag, don't listen to her, blah, blah, blah. That's got to go.
We're making birth scary.
Because I'll tell you, women are godly. And the fact that they can create life is not something to be giggled at or pushed aside. Yet, in modern health classes in high school, they teach, here's a penis, here's a vagina, here's how it works, blah, blah, blah. But they don't teach the reverence that you should have for that and an understanding that these are normal bodily functions. It's very healthy for you to have your period every month. The idea that my profession has pushed birth control pills for women who have slight menstrual irregularities rather than trying to figure out why they have slight menstrual irregularities. We just put a mask on something for 10 years, and then finally she wants to get pregnant, and now she's got problems because no one bothered to understand what was going on, and she didn't either. I've had
many women who said they wish they would have known that even like what birth control could have done to them. They're being given out like water, like no big deal, and then they don't realize years on end, and then when they want to conceive, that they have some underlying issues that they could have taken care of a long time ago. Do you?
Yeah, no. Look at Vicky. Vicky, I was guilty of all that. I did all those things. The question is, why are doctors still doing them? Because now we know. We should have known then. I should have known when the birth control people brought us really nice lunches and took us to Laker games, that there was something amiss. But it was just business as usual in the doctor's office, with the drug reps coming in and telling us that birth control pills can solve all your problems, as long with and like formula and everything else. Formula is better than breastfeeding, and
right.
There were years where we gave women injections to dry up their milk so they wouldn't get engorged, so they could bottle feed without engorgement, because we were taught that was, and I did those things. And there are still doctors that tell women those things. They tell women they should have 4 vaccines while they're pregnant. Right. None of which have ever been tested for safety alone, let alone giving 3 of them at the same time. And they push it. And if you don't take it, then you're labeled that hard patient or that difficult patient, or she's non-compliant. And that's put in your chart, and that follows you for the rest of your life, because now it's in your big HMO's chart that you decline something. It's like, as if declining something is like something to be punished. So those are 3 things that you can do: education, health savings account, do your homework. And then there's big things on the larger scale, and some people are going to need to take this on, and that's going to be something like tort reform legislation. Doctors are very defensive in their medicine. They over-test, which then leads to false positive results, which then leads to interventions, that whole cascade that people talk about. And then you end up with an induction and a baby that doesn't tolerate an induction, surprisingly, shockingly. and you end up with a C-section. And that's why part of the reason we have the C-section rate that went from 5% to 35% in a matter of 50 years, with, again, no improvement in outcomes. In fact, there's evidence of non-benefit, not just neutral benefit, from all that they're doing, because of the long-term effects that being born by cesarean section may have on that mother and that baby, which again are not quantified because no one studies them. And if they do study them and they put a paper out that says it's detrimental to have C-sections this high, it's ignored.
Wow.
Because it's not the narrative. And sometimes it's even hard to get an article like that published, because if you do, you might end your career.
It's like when you talk about home birth.
Right. It's why I had to go outside of the main journals to publish 4 papers that are very interesting papers, whether you agree with me or not. They're worthy of discussion, but the main journals in the United States wouldn't touch them. And I had a conversation with the editor of the Green Journal, which is the ACOG's journal, and it was very cordial, and she was very nice, and we had a conversation, and she read one of my papers, and she said, "Stu, this isn't going to get through peer review. They're just not ready for your stuff." That's I'm paraphrasing, but that's sort of what the conversation was like. And it's true. They don't want to know this stuff because it makes them uncomfortable. Because if you're doing 40% C-sections in your practice, you have to know that at least half of them are unnecessary. And you're putting the woman through major abdominal surgery half the time unnecessarily. So you can't admit that, because it's unthinkable to think that you're actually doing something that's that bad. So they have to rationalize and justify how they do that. And there are coping mechanisms for that sort of cognitive dissonance. And one of them is to just say that C-sections are safe and just ignore the literature. I mean, they are safe, relatively speaking, yes, but they're not safe in the manner that we're talking about, which is what's better for mom and baby. And or then you ridicule anybody that tells you otherwise. So you call that crazy guy that's doing home breech delivery.
Yeah.
And you get labeled with those sorts of things.
You know?
Breech is dangerous. Correct. The head will get stuck and the baby will die. But that's not what the literature shows. And some of the worst injuries to breech babies occur at cesarean section, because the baby still comes out breech, and the doctor who doesn't know how to do a breech delivery is still delivering that baby breech. It's just through the abdominal incision rather than the vagina. So they don't teach the skills anymore.
Knows that.
Oh, they don't know anything. I mean, most people don't know much about these things because
my baby's breached and, it's dangerous and I have to have my C-section.
And if I have twins, I have to be induced at a certain time, or I have to have a C-section if one of the babies is breech. If I'm diabetic, I have to be induced at a certain gestational age. I have to have all these ultrasounds. No, you don't.
Or if I have a big baby, I have to get induced. That's the common one.
This gets me into the question.
C-section.
Yeah, this gets you in the question of the real question that people need to understand is that there is no definition for high risk, because almost every pregnant woman in some way is labeled high risk. I don't think there's very many pregnant women that get through their prenatal care with a standard obstetrician that doesn't have something on their problem list that the doctor would then label high risk. And so I've done a lot of research and deep diving into this, and high risk is not a number. High risk is something that makes your doctor uncomfortable.
Interesting.
And the problem, of course, is that they don't individualize care. They have algorithms for every diagnosis. So if you're hypothyroid, you get this. If you're diabetic, you get this. If you're over 35, you get this. If these things are not high risk. And as you mentioned, big baby. So I do this thing when I teach my 2-day seminar, and I go through a list of things that tell me which is high risk. Giving birth to vaginally to a big baby, or your doctor thinking your baby is too big. Now, doctors will say, giving birth to a baby that's big is high risk. I will tell you it's much riskier to the woman and her baby when the doctor is fearful that the baby's too big. Or which is worse, which is riskier, having a breech vaginal delivery or having a C-section for breech, but wanting a second and a third and a fourth baby.
Correct.
They will tell you the breech vaginal delivery is high risk. I will tell you that even by numbers, the risk to the mother and mother's future babies is higher statistically than it is that first baby having a breech vaginal delivery. Yet the first one will be labeled high risk, and the idea of having VBACs and possible placenta accretas and all that stuff is not even considered. They'll say that a woman's over 35 is high risk. So they'll want to induce her, which is a greater risk, being over 35 or having a labor induction.
Exactly.
But so the solution to their problem is actually riskier than the problem they want to solve. And that's because that's why high risk does not have a definition. And doctors are trained in fearful birth. That's how they're taught in medical, well, not really medical school, residency, is they're trained. And by the way, maternal fetal medicine specialists have taken over the training of OBs. And what do maternal fetal medicine specialists specialize in? Problem pregnancy. So if they're seeing every pregnancy through that prism, you can understand how they get that way. Who should be teaching residents about normal vaginal delivery? Midwives.
Good question. Midwives. Exactly.
Midwives should. Now, you mentioned earlier that midwives are considered, like a lower. They're like called mid-level providers.
Yeah. Unfortunately, when I speak to clients or I speak to people and when they're telling me what they're looking for, or let's try to have a TOLAC, or I want this and this and this, I'm like, you're looking for a midwife. And they're like, no, but I need an OB-GYN. I need someone with a higher level. Nobody would be okay with me taking a midwife. When I speak to my mother, my brother, my next door neighbor, uncles, aunts, apparently they're all involved, that, I can have a midwife. And it's mind-boggling, because if we only know, and if they only see how I know I'm a birth assist for a group of home birth midwives, and I'm also in EMS, I'm also a doula, I run a doula agency, so I'm in all worlds. I see it all. And if you understand all the trainings and everything, and how they don't blink twice, and how they deal with shoulder dystocia, how they deal with breech, versus how I've seen it in hospital, it's like, I don't want to say that one is less of, but in a way, the midwives tend to be more skilled.
I'll say it.
You'll say it.
Midwives are more skilled than OBs at delivering babies. That is their specialty. Midwives are not a lesser subset of obstetrics. Midwives are a separate profession. They should never be governed by obstetricians. These laws that they pass that say a midwife can't practice unless she has physician supervision is so patriarchal. It shows a complete lack of understanding of the midwifery profession. And now, because medicine understands that, big medicine does, and because they're tyrannical, they're now trying to take over midwifery schools. And they're becoming more medicalized. And governments are claiming that the word midwife belongs to the government. Midwives are great because midwives are experts in normal birthing. They're very quick to recognize abnormal. Whereas doctors who are experts in abnormal birthing see everything as abnormal. Therefore, they can't even differentiate normal from abnormal anymore. Why am I saying these things? I have respect for anybody that makes it through medical school and residency. You have to give up a decade of your life to do this sort of thing. The problem is these people need to wake up and to look at their outcomes. And you mentioned something about the social world and the pressure people feel and the lack of knowledge of what midwives do. This is another thing when we were talking about things that families can do to help improve their experience when they're pregnant. Is this is your pregnancy? It's very private. Your parents weren't there when you were conceiving this baby. They don't need to be involved in every decision that you make, no matter how close you are with your mom and dad. They may not agree with you. And all you're going to do by bringing people in that aren't like-minded is you're going to create doubt and fear and anxiety. And you're going to feel that. Even if you aren't talking, your mother lives across the country and she knows you're having a home birth, you can feel her worrying.
Of course.
From 3,000 miles away. You can feel that, okay? There's no question that you can. So if you're doing something that you think that your parents aren't going to be, or your sister or your other or friends aren't going to be supportive of, keep it to yourself. Don't add that extra level of anxiety and stress upon you during a time when you should be resting and nesting and enjoying yourself and bathing your baby in dopamine and oxytocin and not cortisol and adrenaline and remember, although the baby's forming inside of you and the environment around you and the things that are going on in your own brain and your own body are affecting epigenetically how that baby is developing inside of you. So you need to be as happy as possible. You need to surround yourself by like-minded things. Don't watch horror movies. Don't watch the news. Okay. Really don't, because the news is there to titillate you and to get you aggravated so that you'll click on more stuff. That's what it's for. So you cannot believe anything that you read on initial face value. You have to file it and you have to research it and you have to figure it out. But I will tell you that one way to determine those things that I've found is if something tends to agree with what common sense would dictate, it's probably true. And if it disagrees with what common sense would dictate, it's probably not true. Therefore, the ARRIVE trial, which says it's better for women to have all babies induced at 39 weeks. That doesn't really fit with my common sense feeling inside of me. And it turns out when you look into the ARRIVE trial, it's a completely flawed trial and it's not reproducible. It's not something you should be doing it. And yet doctors just jumped on it because they want to control birth, because they feel comfortable when they're in control and birth can be chaotic. And birth doesn't run on a timetable.
Nope. And
yet everything that doctors do runs on a timetable. They're always looking at their watch. You're moving too slow. You're not dilating fast enough. You're going beyond 40 weeks. But that's all they know. And it makes them uncomfortable. It gets back to the whole thing that I said about what is high risk. It's something that makes your doctor uncomfortable. If your doctor's not comfortable for whatever reason of you going past 40 weeks or 41 weeks or 39 weeks or whatever, I mean, think about how stupid those numbers are. It's a bell-shaped curve. Michelle O'Donnell, who passed away this year, used an analogy which it's a simple analogy and it makes perfect sense. If you grow apples on a tree, you don't pick them all the same day.
Right.
Because if you wait to pick them all the same day, some are going to be red, some are going to be green, and some are going to be rotten.
Mm-hmm.
You pick them when they're ready. It's the same thing with babies. Not every baby is at the mean of the bell-shaped algorithm for gestational age. Some babies come at 34 weeks. Others babies come at 43 weeks. They're the extremes, but they don't necessarily have to be abnormal. We have to put all babies at, the cutoff of 40 weeks. Well, 40 weeks is the median of a bell-shaped curve. That means that 50% of babies generally go beyond 40 weeks. And if you ask most moms or most midwives, they'll tell you, first-time moms generally go beyond 40 weeks. I don't know if that's true or not. Probably isn't. But it may be more true because first-time moms tend to worry more. And when a mom is worrying, that's not a great place. It pushes labor. It delays labor. Like any mammal, when they're going into labor, if they're anxious because there's a predator approaching or a forest fire or some other thing, labor's going to stop and they're going to get up and they're going to run until they feel safe. It's the same thing here. So I don't know, but I know it's really stupid to think that going beyond 40 weeks is a problem. It is not, but we've convinced women that it is. And so now if a woman goes beyond 40 weeks, she may feel fine about it, but she's having lunch with her girlfriend.
But now she's getting nervous.
Now she's what?
She's getting nervous because of all the pressure and everybody's like, oh, my pet's
She goes to lunch with her girlfriend. Yeah. And her girlfriend says, oh my God, you're past 40 weeks. My doctor says it's really dangerous to go past 40 weeks. And now you've just thrown that seed of doubt into her world. Why would you do that? And again, a lot of people, and again, people socially aren't, sometimes they don't take their cues well. And they say stupid stuff. We all do it. I'm not saying these things because I'm above all this. I do it all. I don't do it as much as I used to. But like, it's a simple example. You have people over to watch the football game, and you've got this new 60-inch television. And one of your snotty friends says to you, oh, yeah, that's a nice TV. Where'd you get it? And you say, oh, I got it at Costco. You got it at Costco? I could have got it for you at Sam's Club for cheaper. It's like, shut up, you. Yeah. Why did he have to say that? Because he wanted to feel important. He wanted to feel part of the conversation. But he doesn't know what he's doing is he's making the other person feel bad. Right. This is what your mother-in-law will do. This is what your friends will do. They don't mean to make you feel bad, but they're not thinking. They're projecting their own experiences onto you. And that's what obstetricians do. What we really need to do is learn to individualize each woman's care based on her own life story and life experiences. And the midwifery model, the traditional one, allows for that. The medical model does not. The medical model works on volume and algorithms. So to them, you are a number. Your doctor may know you. He may call you by your name. He may remember your husband's name. He may remember your other children's names. But you know what? When you go into labor, he or she is not on call. You have a stranger. Now you're being taken care of by somebody you don't know. Do you feel safer or less safe in a system that works on a shift? So people will say, I feel safer in the hospital. That's fine. But think about what you're saying before you say that. If you're saying, I feel safer because there's an operating room 30 feet down the hall, that's fine. But two things are true about that. One is that because you're in the hospital, you're more likely to need that operating room. And the other thing is just because there's an operating room 30 feet down the hall doesn't mean that if your baby suddenly has a decel or crashes because of something that's happening to you in the hospital, that they're going to be able to get that baby out in time. Because they have to have an anesthesiologist, an OR crew. You have to have an OB assistant surgeon. You have to have all those people have to be around. Sometimes it takes 15, 30 minutes to get those people gathered together. So just because you're in a hospital where something more likely bad is going to happen because of the way you're treated in the hospital, doesn't make it safer because there's an operating room down the hall that isn't necessarily readily available. And only in rare hospitals do they have OR crews and 24-hour anesthesia available. Right. And, most community hospitals don't have that. So it's going to take a while to get a baby out, even when a baby is in dire straits. So where are you more likely to not have a baby in dire straits? At home. Now, again, we're not talking about that. We always have to make the caveat. We're not talking about those women that need to be in the hospital. But I'm saying you take a equal cohort of women that are classically low risk.
Low risk.
And there's no definition. But let's just say a similar cohort of women, and you put them in the hospital, you put them at home, the ones at home are going to have better outcomes. Statistically speaking, in pretty much every aspect of birth. Shorter labor, less episiotomies, less lacerations, better satisfaction, better outcomes for babies, less babies to the NICU, less obviously operative deliveries or cesarean sections, all that stuff. You're going to have better outcomes at home. Now, you're going to have every now and then, you're going to have a really bad outcome at home. And people will say, well, if you've been in the hospital, that wouldn't have happened. But they have very bad outcomes in the hospital all the time. I like to tell this story, not because it's a good story, because it's a sad story. But there was a woman that I got called to come and put a vacuum on at a birth center when I used to practice in Los Angeles. And I was an hour away. And she'd been pushing for 3 hours. And the midwives called and said, can you come? We can't get this baby to come out. And I said, sure, but it'll take me an hour to get there. And they said, fine. And I got there. And by the time I got there, the baby was crowning like the size of Major League Baseball. So it just really didn't need a vacuum anymore, just a little fundal pressure. And we got the baby out. And the baby came out and it needed a little bit of resuscitation. But within a minute, its heart rate was good. Its color was good. Its breathing was good, but it had no tone. There was something wrong with this baby. So, we checked the O2 sat on the baby, was fine. It was 98%. The baby was doing fine. Just had no tone. It was neurologically something wrong with this baby, which in hindsight was probably the reason that it took this woman so long to push it out.
True.
It's harder to push out a wet sponge than it is a baked potato. if you get my analogy. Right. Okay. So we eventually called the paramedics. They came and we were standing around talking, and we decided that, this is now 45 minutes have gone by. The baby's breathing on its own. It's doing fine. It has no tone. Just pick up its arm, it drops its arm. So we said, there's something wrong with this baby. So we take to the hospital. The mother gets cleaned up. She goes over to the hospital. The baby's in the NICU. And I'll just make the end of the story before I tell you the moral of the story. The end of the story was that 30 days later, the baby passed away. Baby had something neurologically wrong with it. To this day, we really don't know what it was, but there was something. Maybe it had something genetic. Maybe it was something that happened in utero. It wasn't in labor. The heart rate was fine. Baby obviously afterwards was just fine. There was something neurologically wrong with the baby. When the mother gets to the nursery, the nurse mumbles something under her breath about frickin' home births. Now, first of all, it was a birth center birth. Doesn't matter, but frickin' home births. Stupid thing to say. First of all, even if it was true, you don't say that in front of the mother. But secondly, this baby's the birth had nothing to do with this baby's issue. The nurse was just having a bad day, or is just a mean person, or whatever. But the mother, in all her grief, said something, and this is a composite memory. It's not exactly what she said, but she said to the midwife, I count 13 babies here in your NICU. Where did the other 12 come from?
That's a good one.
They were all hospital births.
Right.
So why did the nurse say that? Why did the nurse say something like that? Do you think that all 12 of those babies came into the hospital damaged? Or do you think that some of them came into the hospital in perfectly fine condition inside their mother, and during the process of whatever the hospital was doing to them, they ended up going in fetal distress and ending up needing to go to the NICU, or maybe not even needing to go to the NICU, but we're in the NICU.
We're just in the NICU anyways.
Well, it's a revenue generator, so let's not put that aside. The hospitals find reasons to put babies in the NICU. But the stupidity of this nurse to say something, first of all, socially, it's just idiotic and mean. But secondly, to have no realization. Healthy babies end up in the NICU every day in hospitals. And no one says it's the hospital that did it. There was a meme on Instagram just recently that said, when there's a bad outcome in pregnancy at a hospital, it's because birth is problematic. When there's a bad outcome from a home birth, then it's because home birth is problematic. It's like,
Yeah.
but they left the word
the
hospital.
midwife is at fault. Or we
Yeah,
are
they
in the
left the word
hospital. It's
hospital.
like, thank God I was in the hospital.
Yep.
And thank God they saved me. And thank God.
And you know what?
There.
You know what, Vicky? It's podcasts like yours and mine and just putting the word out. We are not. We don't have a big bully pulpit. We're not going to change hundreds of thousands of minds tomorrow, but we are changing one family at a time. And I know that because I get people writing me all the time saying thank you. We listened to the podcast, or we heard you talk, or we came to your seminar, or we came to the Breech conference in Kentucky or whatever, and we learned something that we didn't know, and we started to investigate, and we realized it, yeah. And me and my partner, we had a home birth, and it was best thing ever. Or I had a redemptive home VBAC after my initial induction for my first baby, ended up in an unnecessary C-section. And it's never great for women to find out that the C-section they had or the intervention they had wasn't necessary. But women are discovering that. Right. Because I'll tell you that, in 1990, less than 10% of women were induced. Now over 30% of women are induced. This is CDC data. So
wow,
take it for what it's worth. But the rate of induction has tripled in the last 35 years. Have outcomes improved?
No.
As I've said, the rate of C-section's gone up 700% as the outcomes improved. The rate of use of ultrasound has increased astronomically. Has outcomes improved? No. What has improved? The financial stability of the maternal fetal medicine profession has improved. But the outcomes haven't improved. Now, they'll be argue, yeah, well, we saved one baby. Yeah, you will save some babies. And that's wonderful. But at what cost? To all the other women who got induced or got intervened upon and then suffered a consequence from that, which doesn't show up in your statistic because you're only looking at, outcome, at neonatal mortality or morbidity. You're not looking downstream. You're not looking at anything else. There's a number in research that's called the number needed to treat. Mm-hmm. And in many papers, the number needed to treat for to save one baby who's breech, is you have to do 447 to up to 600 and some cesarean sections to save one breech baby.
Wow.
So you might say, well, that's great. If that's your breech baby that we saved, that's great. But what happened to the 476 women who didn't need the C-section? No one looks. Did they rupture their uterus in a subsequent pregnancy and have a brain-damaged infant? Did they have a placenta accreta and have a hysterectomy? No one looks. Because all they care about is that live baby in the bassinet, which is going to be on my tombstone, by the way, my saying about that. But, yeah, so we've just made a big argument why people need to wake up and realize that the hospital and the medicalized birth model does not have your best interest at heart, and it doesn't even have the best outcomes. For some women, it's where they belong, but you need to be informed. And if you look at this information and that's where you feel safe, and you have a doctor, and that doctor is somebody you trust, and that doctor says, yes, I'll be there when you're in labor, that's you hang on to that person, because that person 100%. Is very valuable. But doctors don't work that way anymore. Most doctors now are employees. They're not independent like I was. You asked me at the beginning how I could speak up and speak out, because I was always self-employed. I didn't have partners coming down on me saying, Stu, you can't do that.
You can't say
Stu,
that.
you can't speak to that. You can't speak to the LA Times. I had I gave a interview to the LA Times one time. They were doing a story on nursing shortages and how they were having a problem with outcomes. And the head nurse at Cedars had said to the reporter at the LA Times, I remember the reporter's name, I remember the head nurse's name, said to them that there's never been a bad outcome at Cedars because of nursing shortage when they were doing this interview. And I'd had one. I'd had where they made a nursing error because they'd had a floater come in who didn't know anything about antepartum care, who misdiagnosed a problem with one of my patients during the night, and the patient ended up miscarrying. And so I called the reporter and I spoke to the reporter. By the way, this was after I'd written the administration and my chair of my department probably half a dozen times about issues like this. And I spoke to the reporter, and the reporter put it in the newspaper, and I got called into the principal's office. How could you do that? How could you go to the reporter? He said, why didn't you come to us? Guys, I wrote you 6 times and you did nothing. You didn't respond to me. So your chief nurse at the hospital lied. And I wasn't going to let her get away with it because it cost one of my patients her baby. And they weren't happy with me. But if more doctors began to speak up, then they wouldn't be ostracized. The problem is doctors now, because they're employees, because they're salaried, they work a shift, their pension, their holiday pay, their Christmas bonus is all dependent on them being good little soldiers. They're not going to speak up anymore, and they've lost their ethical way. Because our ethical obligation as practitioners is to the woman or the patient we're caring for, and not to the institution. And once a doctor becomes a salaried employee, his fiduciary duty is now compromised because, well, for obvious reasons.
Right.
He may have to skew what he says to a pregnant person. I just use that term. I hate that. Pregnant woman.
Yeah.
I was just thinking in men in general. I was thinking patients in general. That's what he may have to skew what he says to a patient, because we're not just talking about obstetrics here,
Right.
to comply with the hospital's policy or his employer's policy. A good example would be that we don't, like Kaiser in Southern California doesn't want women going past 41 weeks. So when a woman is 40 and a half weeks, they're gonna have to start telling them about the perils of going past 41 weeks and skewing their counseling to get that woman to be induced. Because if they were honest with her and said, your babies are fine, or your baby is fine, we don't have to do anything now. We can just continue to watch and maybe test once a week or twice a week and just let you go. And then you go into labor at 41 weeks and 5 days, and that person isn't on call, and the other doctor's on call and finds a woman coming in at 41 weeks and 5 days. He's going to report you. You're going to get yelled at. You're going to get called into the principal's office like I did, and you're going to be yelled at. So why would a doctor want to do that and risk his salary, risk his bonus, risk his job to, when I say salary, I mean promotion. Sorry about that.
Yeah.
But risk his job to be honest with the woman. Why would he do that? And the only reason to do that is because you ethically are duty bound to serve the needs of your client. But my colleagues have forgotten that. The system doesn't care about that. They'll say one thing, but again, it's always about actions, not words. Look at the actions, look at the outcomes, and then you can see how they're doing. Right. And so we need some people to run for Congress and run for state legislature to help make the changes, because that's where the changes are made. And state legislatures and congressmen, they don't know anything about birth.
Right.
So where do they get their information from? From lobbyists.
The providers. Yeah.
From lobbyists. And who are the lobbyists? They're the ones with the most of the gold. Back to the old golden rule. ACOG, the American Academy of Pediatrics, the American Medical Association. And who are they lobbying for? They're lobbying for themselves. They're not lobbying for the individual woman. We have no say. Practitioners like me, solo practitioners, or people outside the mainstream, I don't have a voice. I mean, I have a small voice, but I'm not going to get them to pass legislation to change rules on how midwives have to be supervised, or midwives, and the whole thing about licensing.
Right.
Licensing is a facade. Being a member of ACOG or being a fellow, being a board certified, doctors that are board certified, that doesn't make them better doctors. The board will put up advertisements saying that because they want doctors to think they need to be board certified, and then hospitals will make you be board certified in order to have privileges. But board certification, I can tell you two examples of why it doesn't mean anything. One is, if I'm board certified today and I give up my board certification tomorrow, am I a worse doctor? Nope. And two, most of the stupid stuff that's led to the outcomes of where we are right now the 30, 40, 50% C-section rates, the induction rates, the NICU admission rates, all the, the chronic disease rate in our children, all those things have been created by who? By board certified fellows of the American College of OB-GYN or the American Academy of Pediatrics, licensed in their state. And, all these doctors that have been pushing the COVID vaccine, all these doctors that have been telling you need to be induced at 39 weeks, they're all board certified fellows of ACOG. So did that make them better doctors? No. It's a club.
It's a club. Yeah.
Yeah. It's a club. It's like belonging to a country club. You want to be acknowledged. You want to be a member. Listen, I was so proud when I went to my cap and gown ceremony for the fellow of the American College to become a fellow of the American College of Gynecology. My parents flew out. It was in Las Vegas. I took my mom to see Barbara Streisand. I still remember. This is how old it was. This is how old I am. In concert, and it was a proud moment for me. Little did I realize what a corrupt organization they are. Right. So, and yet they're the ones that are going to dictate to families and to midwives and stuff how they're supposed to practice. This is distressing. Some people have been listening to this and their stomach's in a knot, or they've turned it off because they can't handle this. And I don't blame them, because it's upsetting. You want to be able to trust somebody somewhere, but it's very hard to do that. And sometimes trust is something that the further away you get from your core, the less people care, the less concern you have. We care more about people that we love than we do about our neighbor. And we care more about our neighbor than we do about somebody that lives across town. And we care more about somebody that lives across town than somebody that lives in another country. That's just how human nature works. There are exceptions. There are obviously altruistic people, the Dalai Lama, Gandhi, I don't know. But most of us are not like them. And so you have to take care of yourself, is my point. You have to assume that the person that's taking care of you, especially if they're a salaried employee working a shift, isn't going to care as much about you as a private midwife or a private OB, for that matter, who
that's not taking
feels responsible for
insurance.
Right.
Yeah. Like when the main ones that are on top of my head that I recommend, most of them either don't take insurance or take something on the side because insurance is not paying enough and you have to switch over to, and they're like, but they're so expensive. But so we are not going to pay. And then at what cost to you if you go to just the standard care of someone who does take your insurance?
Yeah, we just talked to a guy on our podcast that's going to come out in 2 weeks from an organization called Crowd Health. I don't know if you know who they are, but they're like a health sharing organization. I mean, a cost sharing organization, kind of like the Christian Ministries or Liberty Health Share. So they're not an insurance company. And again, this is what entrepreneurial people do. They see a problem, and instead of just pissing and whining and moaning about it, they come up with a solution for it. I've sort of gone through my pissing and whining, moaning phase, and now I'm trying to find solutions. The problem, of course, is that the model of care that I think works best is not conducive to doing volume. And we have 3.8 million births a year in the United States. And if the average midwife can do 5 births a month, what is that, 60 a year? Is that right? Yeah. 60 a year. So I don't know, you divide 3.8 million by 60. How many midwives do we need?
A whole lot.
Yeah. And by the way, and their training now is being done by midwifery schools that have been taken over. A lot of midwifery schools don't use the word woman anymore. And I don't know if that offends somebody who's listening, and I'm sorry if it does, but women give birth. That's just how it works.
Yep.
I'm a doctor. I know this stuff. I went to medical school. All right.
Yeah.
What else is on what else do you want to know?
So the end goal is what can we tell my listeners, my clients in regards to okay, they're not open to home birth just yet, or midwives, when they are looking for a provider, what should they be looking out for? And number 2 is, what is one sentence every pregnant woman needs to hear?
Birth is not a disease. Or pregnancy is not a disease. Pregnancy is a normal function of your body. So that you just should understand that. The culture has changed it into something that's scary. Just you watching the movies, the TV, the news, whatever. They only write about planes that crash. They don't write about all the ones that landed safely. I fly all the time.
Correct.
And I'm still here. So pregnancy is not an illness. Pregnancy is a normal function of your body. As far as what to do about a practitioner, don't be trapped by an insurance card or an HMO or something like that, or Medicaid or whatever. Save money for this. Everyone in our world probably knows the wedding analogy, which is a great analogy. Have you heard the wedding analogy?
Yes,
okay.
But say it again for the viewers.
Well, I'll just do it briefly. In traditional woman's life, there are 2 events that are probably the most important in their life, and that is their wedding day and the birth of their children. And for your wedding day, you plan everything. You often spend more money than you have. You may go into debt. Your parents go into debt, whatever. They spend more money than they have. And you pick the venue, and you invite people that you love, and you pick the invitations, and you pick the cake, and you pick the main course, and you pick the color of the napkins, and you pick the dresses, and you do all that stuff, and you plan everything. For your birth, you pull out your insurance card and you go, oh, this guy's been doing my pap smear for 10 years. I'll go here. And that's it. That's the amount of effort you put into it. So the joke is, what if they had wedding insurance? And what if you paid every year from the time you're 18, you paid a small premium every month. And when you got married, your wedding's covered, but you didn't get to pick the venue. And you didn't get to pick the flavor of the cake. And they invited people to your wedding you didn't like. And you didn't get to pick the color of the napkins. Okay. I always use the napkin thing. No one would do that.
Right.
Our culture thinks that would be stupid.
People won't settle for that.
But for cultural reasons, we treat birth this very important thing that you'll probably remember longer than your wedding day anyway, the birth of your children. So we should treat it with more reverence. So that's the analogy, is that we should treat birth in the same way we treat our wedding, and we should give it the same attention. You need to you wouldn't just take anybody to preside over your wedding. You want to pick the minister, the pastor, the rabbi, whoever, the justice of the peace, whatever it is. You want to interview them. You want to pick them. You want them to know your family. You want them to say nice things about you. You wouldn't do that. The same thing with your practitioner. You wouldn't just randomly go in to get married. And I mean, some people just go to the justice of peace. But I'm saying, if you plan a wedding, you plan that. So if you plan a birth, how is it that you plan a birth, but then you have no idea who's going to be the people that are helping you when you're in labor? You don't know the nurses at the hospital because you've never gone to the hospital and met any of the nurses. Maybe you should go to the hospital and meet some of the nurses. There's no guarantee that those nurses might be the ones on when you're on call, but you might have somebody who you get to know. And then when you go in there, you're going to be met by a smiling, friendly face. Same thing with your practitioner. You wouldn't want your justice of the peace to be on a rotation where you never know which one you're going to get. You want to pick the one that you like. So find a practice that's getting harder to do, where you might find the doctor is the one that actually says, yes, I will be at your birth, unless I'm on vacation. And then there's one other person who you treat during your pregnancy so that you feel comfortable with him or her as well. And as opposed to a group of 7 or 10 people where they're just working, and they're actually what are called laborists. So they don't even have a practice. They just catch babies in the hospital. They don't have any invested interest in you. So find independent practitioners, people that you like. When you go to the office, there are red flags. When you go for your very first visit, do not go in as a patient. Go in as a person who's interviewing them, just like you would if you, right, just like you would if you're going, to somebody's coming to do a bid, a contract to paint your house. You may not hire them sight unseen. You may talk to them and you may get a second opinion. And then you may pick the one that seems more reliable, the way it is. So you go in and interview them. Don't let them take your blood pressure. Don't let them draw blood on you. Don't sign any forms. Don't let them pull the authoritative white coat thing on you and be said, now I'm in position of power and you're the patient. You're not the patient at that point. You are just a consumer looking for a service. So go in the first time and see how much time they spend with you. Do they look you in the eye? Do they give you the time? Do they answer your questions? Go in with, ask them simple questions like, what happens if I go past 40 weeks? Who covers you if you're not available? What happens if I break my bag of waters at 39 weeks and I'm not in labor? Simple questions. Do you do breech delivery? Oh no, why not? Just ask them the questions, not in a threatening way, in a very cordial way, but find out. And when you have a practice and you choose one of the red flags that was told to me by the Down to Birth people from their podcast was, most women, when they go to their prenatal visit, they're a little nervous. They're going in. Is the baby okay? Am I okay? What's going on? Stuff like that. The key is, how did you feel when you left the office? Did you feel better or did you feel worse? If you feel worse, why are you going back there? Why are you continually going back there? Because Blue Cross says that's where you got to go? Don't fall for that. This is a wedding. This is an important event. Make it an important event in your life. Put it as a priority. Do your homework. Spend time at night. Read some books. I'm not going to tell you which books to read. I'll tell you one not to read, and that's what to expect while you're expecting. I'll just tell you not to read that one. But I don't care. There are many other books to read. The problem is the most popular book is probably not the best book to be reading because it's a fear-based book. And then get your partner involved. You can be so bonding.
Yes.
And so building of a relationship when your partner is involved. Yeah, he may work days and stuff like that. So maybe try to find an office that has prenatal visits at lunchtime or maybe prenatal visits on a Saturday so that he can come to the prenatal visits. Include him in the decision-making process. Men are very nervous about their woman being pregnant. As most traditional men have two roles, and that's to be the breadwinner and to keep their family safe. And so if a man feels like the safest place to be is in the hospital, that's because that's what they've been told all their lives. They don't know any different. So bring them into the process. And if that's what you both agree on, that's fine. But a man who's involved in the process, a man who sees the power of his woman give birth, the man who's there to even catch the baby, is a man who's going to be a better father, a better husband, and certainly more likely to stay in the family and marriage than a man who's pushed aside and told to wear a poofy hat in the hospital and it doesn't stand up for his woman when she's getting bullied in the hospital because he doesn't know anything. Women want to be protected by their man. And when a man is sitting there while a woman's getting a vaginal exam she didn't want, or getting bullied, or getting threatened, or getting coerced with Child Protective Services hammer or something, or you don't want your baby injured, do you? And he just sits there and does nothing. The woman will not look at the man the same afterwards, and it will take a long time to rebuild that process, that trust, if it's even possible. So, that's a huge thing, and that's something that can come out of this and strengthen the family. If you use pregnancy, the medicalized birth model doesn't consider that to be a factor. It's not part of their algorithm. There's nothing on the prenatal forms that says, how's the husband doing today?
Or how is he feeling? Exactly.
Right. Yeah.
That's one of the reasons why I emphasize so much in my birth education. And when I meet my clients and when I'm my doula clients, I always make sure, I was like, bring your husband, make sure he's involved. He is just as much, if not more so, involved in this process. it's not just about the woman. Everybody talks about the woman, but they forget there's the man standing in the corner, not knowing, or sometimes it's not even, sometimes I find that they don't know. They just don't have who to talk to about this, and they don't know what's normal and what's not, and they get bullied or feared into in the hospital that, oh, like you said, you don't want your baby blind, you don't want your wife to die, and then they're just like, okay.
Right.
Versus understanding. And I have it all the time where husbands tell me, like, Vicky, I thought you were going to take over the birth room, and instead you actually I empower the husband to be involved, do the counter pressure, speak up for his wife, and that's your job as the man, and that's what he could provide to his wife, and his natural oxytocin levels and all of that is not something I could provide for her. We have 3 different roles, and we're a team in different ways.
That's right. And the one thing that, again, I want to stress the need for an independent practitioner, whether it's a midwife or a doctor, if you can find one. It's hard to find one nowadays. And then, of course, the one thing that hasn't been mentioned, which is sort of in the 300-pound gorilla on the table, is having a doula. And I'm all for that. Again, I want the doula to be independent. The problem, of course, is that many doulas now are worried that if they speak up or they do something, they're going to get banned from the hospital, or they're going to. And now hospitals are wanting to start doula services, which means that the doula now gets paid by the hospital, which then is ultimate conflict of interest, because is she going to advise the patient that, no, you really don't need this vaginal exam, or you don't need to have your membranes ruptured, when the doctor wants to do it? The doula says, can we have a minute, doctor? And then the doctor comes back in and says, and the patient says, no, I don't want to do that now. They're going to know that you helped her come to that conclusion, and you're going to be called before your principal. So you need independent. If you're going to be in the hospital, you need independent people working for you. You cannot have employees of the hospital working for you because they are conflicted. It's probably something that most people haven't thought about.
Yeah.
That when that doctor or that nurse...
The doctor says, I know certain providers now, because they're starting to realize people want doulas. They say, well, I have a doula for you. I have a doula that I work with, and she's great, and I'll provide a free doula for you. You don't even have to pay. And they're like, wow, my doctor has a doula for me. But isn't that a little bit of a red flag?
Yeah, that's like the, I'm trying to think of a good fairy tale where they lead the kid into the gingerbread house or something like that. I can't remember exactly how they get them there, but they entice them with something that sounds good, but again, you need to be independent. You have to realize that the system does not have your best interest at heart. Your practitioner may, but your practitioner is compromised in that if they work with or in that system. So it goes. Doctors like me are very rare anymore. They're very few. There are fewer and fewer doctors. And by the way, I would tell you that I'm not saying this because I was one of them, but I think that doctors that refuse to take insurance aren't necessarily greedy. I think they're the better doctors, because they realize what they're worth. What they're worth, and they're not worth 14 cents on the dollar.
Yep.
If they want to charge you $100 or something, they're worth it, and they don't want to get paid $14 by the insurance company and then have to see, 7 women to make up the $100 that they could have gotten from one. They could spend an hour with you instead of seeing 7 in an hour. Of course, no doctor can survive on $100. No doctor's office can survive on $100 an hour. That's just a bad example, but you know what I'm saying.
Yeah, it's that people think that the ones who are taking insurance only, or the doulas they're taking insurance only, it's that, oh great, but they don't realize they have to take more clients, not give you that personal attention in order for them to make up that money, as if they would have done it private pay.
That's right. There is a saying by Upton Sinclair that goes like this. It says, it's hard to get a man to understand something when his salary depends upon him not understanding it. And that's where we've gotten to. at this point, is many doctors are pushing interventions and things because that's what they believe is good, because that's what they've been told, or that's what their system wants them to do. And when you try to tell them otherwise, it's very uncomfortable for them. It gets us back to the very beginning of our conversation, is that my profession is filled with confirmation bias and cognitive dissonance, and something called mass formation. Mass formation is when you want to be part of a collective. You give up individuality. Doctors don't want to stand out. They want to be part of that country club. And therefore, they will do what they're told. And what they're told isn't always in the best interest, often is not in the best interest of the individual woman, whose story should be listened to and should be treated as an individual, not as an illness. There's something called the medical gaze, where doctors begin to see pregnancy as an illness. And so the pregnant woman is ignored because they pay attention to what they consider I hate to use the term affliction, but that's the way it's used in the example, that the illness, whatever it is, becomes the center of the focus and not the person with the illness. They don't look at them anymore as a person. For example, if you come in and you tell me that you've been spotting between periods, my brain is already going to the differential diagnosis of spotting between periods. And I'm going to ask you specific questions about that. But I'm not going to ask you necessarily a whole lot of questions about your menstrual history, your life, your what's going on in your life right now. I'm going to miss the forest for the trees, that sort of thing.
Right.
So there you have it. You're welcome.
I appreciate it. Thank you for taking time out of your day. Ladies, if there's one thing we could take from this episode, is that our bodies are meant for this. Birth is not a medical emergency, and we could reclaim our power. Birth is something that should be normalized, beautiful, and it's not something that we need to be saved from. If we could change one birth story, one woman's mind to do research and have a provider that trusts in her, trusts in birth, then I've done my job. Thank you for listening. Don't forget to subscribe, like, and share. This is Empowered Unplugged with Vicky. See you next time.